Hello, I'm Boon Singh. Today I'm going to talk about the approach to pleural effusions, and this lecture is catered specifically for the undergraduate medical students doing internal medicine rotations. We have three learning outcomes. Number one is to describe a logical and practical approach to assess the patients with pleural effusions with regards to history taking, examinations, and requesting investigations. Number two is to list a differential diagnosis of pleural effusions. Number three is to describe the overview of the management in terms of making diagnosis and treatment of specifically empyema, TB effusions, and parapneumonia effusions. This lecture is built on this prior knowledge, which can help you better understand the upcoming lecture content. And these are anatomy of pleural cavity, mechanics of breathing, specifically the negative intrapleural pressure during normal respiratory ventilations, and the control of ventilations. For people with pleural effusions, these are the possible presenting complaints. Number one, which is breathlessness, and the speed of contact could give clues to underlying diagnosis, whether it is acute or subacute or is a chronic. Number two is a syncope or pre-syncope due to hypoxemia. Number three is cough, which can relate to stimulations of mechanoreceptor. Your further history really depends on your clinical suspicions. Therefore, always have a list of differential diagnoses when talking to a patient. If you are worried about parapneumonia effusions or tuberculous effusions, you should specifically ask for fever, cough, phlegm productions, hemoptysis, night sweat, periodic chest pain, which classically described as sharp chest pain precipitated by respiratory effort. Number two, if you're worried about heart failure, then ask specifically about autopnea, paroxysmal nocturnal dyspnea, palpitations, dependent area edema. Number three, for malignancy, you should ask about loss of weight, loss of appetite, malaise, organ-specific complaint relates to the primary site of the cancer. After history taking, we typically perform a targeted physical examinations. We will specifically look for tachypnea, which is a sign of respiratory distress, cyanosis, which is a sign of hypoxemia, reduced chest expansions, typically on the site of the pathology. This is very helpful if you are performing a short case. Tracheal deviations, if present, it signifies a massive effusions, and the trachea always deviates away from the site of pleural effusions. And stony downers percussions, absence or reduced breath sound, and vocal resonance on the site of the pleural effusions. Other physical signs depends on clinical suspicions. These are the important investigations that you want to request. For imaging, you can do a chest radiograph to confirm the presence of pleural effusions. If you have the skill to perform a pleural ultrasound, it is more sensitive than chest x-ray to detect a small amount of pleural effusions, and it can guide diagnostic or therapeutic drainage. You may want to do a blood gas to look for signs of respiratory failure, and if you are performing a diagnostic or therapeutic pleural fluid drainage, you may want to send for fluid analysis. Look at the fluid for color, appearance, and odor. For red color fluid, it can suggest it is a cancer or infections. Milky fluid can be a chirothorax or it's a cholesterol effusions. Straw color denotes a transudative effusions. If you have a pus, then it strongly suggests empyema. Send for pleural fluid pH, protein, and lactate dehydrogenase (LDH) coupled with a serum sample, and this is to calculate for Light's criteria. You may want to look for cell count as well, whether it's a lymphocytic effusions or it is a polymorph predominant effusions. This is a chest radiograph to show an example of a pleural effusions. Let's focus on the site of the pathology, which is the right hemithorax. On the right hemithorax, you can see a meniscus sign, which denotes the level of the pleural effusions, and the loss of costophrenic angle on the right diaphragm, with the opacifications of the right lower thorax. All of these are suggestive of right pleural effusions. Now we have performed a pleural drainage. We will now send the pleural fluid together with patient's blood sample to the laboratory for further analysis. We will later interpret the lab result based on Light's criteria, which is by far the commonest used method in clinical practice to differentiate between transudative and exudative pleural effusions. And this has clinical implications because it can guide us to the differential diagnosis. Each of the transudative and exudative pleural effusions have its own unique etiology. So in clinical practice, it may not be so straightforward, and there may be a gray area, but for the purpose of this lecture, transudative pleural effusions means the pleural fluid to the serum LDH ratio of less than 0.6, pleural fluid to serum protein ratio of less than 0.5, pleural fluid LDH less than 2/3 of the upper limit of normal, and this is transudative. For exudative pleural effusions, the fluid to serum LDH ratio of equal or more than 0.6, with pleural fluid to serum protein ratio of equal or more than 0.5, and pleural fluid LDH equal or more than 2/3 of the upper limit of normal. Moving next, I will show you 3 published clinical cases to demonstrate the applications of this lecture's knowledge into a clinical practice. The case 1 is about empyema. It is a case published by Padmanathan in the journal Pneumonia. Essentially, the author described an 85-year-old Englishman who presented with 3 days of worsening right-sided pleuritic chest pain with breathlessness and non-productive cough. His past medical history consists of left ventricular failure with transudative pleural effusions 1 month before admissions, history of Streptococcus galalyticus infective endocarditis. The gentleman has ischemic heart disease, severe mitral stenosis, atrial fibrillations, and hypertension. Physical examinations: he is saturated under 4 liters of nasopron oxygen, respiratory rate of 16, is tachycardic, blood pressure of 120/60, afebrile. He has raised jugular venous pressure, hence the solid murmur at mitral area radiate to the axilla, and there's a dullness to percussions in the right middle to lower zones with reduced breath sound noted in the same area. He has pitting edema. Here are the investigations that have performed on these patients. We will first focus on the chest radiograph on the right side of the screen. So the chest radiograph shows the abnormalities is on the right hemithorax. So on the right hemithorax, you can see a meniscus sign, the loss of costophrenic angle, and opacity beneath the meniscus sign. So it suggests of right pleural effusions. Next, we'll look at the blood investigations. He has white blood cell count of 2.7, CRP of 268, which is high. And the pleural fluid analysis shows that the pleural fluid pH of 7.1, anything less than 7.2 indicates empyema. And the pleural fluid analysis is the exudative picture, which further support the diagnosis of empyema. The fluid gram stain shows a gram-negative bacilli, which later identifies as Salmonella enteritica. Now for empyema, the specific management outline are chest tube drainage, targeted antibiotics. The durations of antibiotics depends on the success of the source control in terms of drainage and the resolutions of the empyema. It can typically be between 2 to 6 weeks. Pain management and oxygen support. Now we move on to case 2, which is on tuberculous effusions. It is a clinical case published by Sharon and colleagues in Respiratory Medical Case Report in 2016. Now the author described a 22-year-old Asian man who is a smoker. He presented with 10-day history of non-productive cough, subjective fevers, night sweats, right-sided pleuritic chest pain, and increasing shortness of breath. 1 week prior to current presentations, he was empirically treated for a pneumonia with levofloxacin without much improvement. Significantly, both parents have been diagnosed with tuberculosis before his birth with unclear treatment status. On examinations, he is afebrile, but tachycardia with tachypnea. His blood pressure is 102/58 mm mercury, and his saturation is 95% on room air. There's a decreased right-sided breath sound. On this slide, you can see 2 chest radiographs. Panel A is an AP view of a chest radiograph, and panel B is a lateral view of a chest radiograph. So both chest radiographs, you can see there's a hydropneumothorax on the right hemithorax. Here are the investigations that I have performed on this gentleman. From the pleural fluid analysis, we can say that it is an exudative effusion because the fluid protein and the serum protein ratio is more than 0.5 and the fluid LDH was elevated. It is an lymphocytic effusion with a raised red blood cell count. The pleural fluid adenosine deaminase is 57.5, which is elevated. The serial AFP smear and culture from pleural fluid was negative. This is not surprising because the yield will be low from pleural fluid. The team has proceeded with a pleural biopsy which demonstrates 1 plus of acid-fast bacilli on smear, and the histopathology shows necrotizing granulomatous inflammations. The diagnosis of pleural TB was confirmed later when the culture was positive for Mycobacterium tuberculosis. These are the specific management outline for tuberculous effusions, which are chest tube drainage and adequate antituberculous therapy consists of intensive phase of 2 months of ethambutol, rifampicin, isoniazid, and pyrazinamide, and 4 months of rifampicin and isoniazid, and with a monitoring of the treatment side effect and also public health measures of contact tracing. Now we move on to the last case, case 3 on parapneumonic effusions published by Craig et al. In CMAJ in 2013. The author described a 44-year-old man presented with 10-day history of fever, night sweats, productive cough, and a right-sided periodic chest pain. He has a history of alcohol abuse. 2 weeks before, he was assessed in the same emergency department after he was found obtunded on a park bench. He left the following days against medical advice. On current examinations, his fever with a temperature of 39 degrees Celsius, oxygen saturation of 87 on room air, poor dentition. There's a dullness to percussions on the right vase and bronchial breath sound in the area of the right lower lobe. On this slide, you can see 2 chest radiographs. Panel A is a PA erect view and panel B is a lateral view. So the pathology is on the right hemithorax and there's a consolidation on the right lower lobe with a blunting of the right corsophrenic angle suggestive of pleural effusions. Now we look at panel B on the lateral view. The height of the pleural effusions is 10 cm from the diaphragmatic pleura. Now the specific management outline for parapneumonic effusion in this gentleman is a chest tube drainage because the pleural fluid analysis suggestive of a complicated parapneumonic effusions with raised LDH and a low pH. He would need antibiotics, and we should offer a stop alcohol advice because the etiology is an aspiration pneumonia given the final fluid culture growth Fusobacterium nucleatum and a species of Peptostreptococcus. We have come to the end of this lecture on the approach to pleural effusions. We have covered the presenting complaints of a patient with pleural effusions, the key examinations findings and investigations to consider, and the principle of management for someone with pleural effusions. If you have questions, please leave on the comment sections and I'll try my best to answer. Bye bye.